This presentation is brought to you by VentLab Corporation. Located in North Carolina, VentLab is a leading manufacturer of respiratory, anesthesia, and critical care products. The following video and dialogue is not intended to be used as a training aid for CPR or manual ventilation. Its sole purpose is to illustrate several well-documented occurrences and subsequent complications that can arise during CPR and manual ventilation. Bag mask ventilation. During resuscitation and manual ventilation, there are a number of documented physiological events that can occur and contribute significantly to poor survival rates. This is especially true on an unprotected airway in conjunction with cardiac arrest. The following illustration shows how the quality of the resuscitation effort during manual ventilation can minimize or eliminate some of these life-threatening occurrences. Optimal ventilation occurs when 100% of the desired volume of a manual breath is delivered to the lungs. To achieve this goal in an unprotected airway, the peak pressure of each delivered breath should be below 20 centimeters of water. This provides maximum opportunity for desired volume delivery and gas exchange. Problems arise when delivered breaths are given at pressures in excess of the lower esophageal sphincter opening pressure of approximately 20 centimeters of water. At these high pressures, a significant portion of each breath is diverted from the lungs to the stomach. This well-documented occurrence is referred to as gastric insufflation. While a number of factors can influence the distribution of a given breath between the lungs and the stomach, one of the most documented causes of gastric insufflations is high peak airway pressures. With each high-pressure breath that is delivered, the stomach inflates while depriving the patient of much-needed volume and oxygen to the lungs. As the stomach inflates, pressure increases in the chest cavity and constricts the heart. This increased intrathoracic pressure reduces venous return and inhibits the heart's ability to fill with blood. The result is poor cardiac output and reduced blood volume delivery to the vital organs. In addition to increasing intrathoracic pressures being shown, the stomach continues to inflate to the point that vomiting is imminent. When a patient vomits and subsequent breaths are delivered, it is likely that the patient will aspirate their stomach contents into their lungs. Aspiration of oropharyngeal fluids and stomach contents into the lungs often causes aspiration pneumonia. Published studies of ventilator patients who contract pneumonia show that the cost of treatment increases by $20,000 to $30,000, and more importantly, up to 30% do not survive. It is not uncommon to achieve a completely successful resuscitation, only to have the patient end up on a ventilator several days later due to aspiration pneumonia. Having an integrated pressure manometer on your resuscitation bag is an effective tool that allows caregivers to monitor and control delivered inspiratory pressures during manual resuscitation and ventilation. Monitoring and controlling airway pressures during manual ventilation minimizes the occurrence of life-threatening complications, leading to improved patient outcomes and greater survival rates. Manual ventilation of intubated patients. Studies show that the use of a pressure manometer improves the accuracy and reduces the variability of peak airway pressures, which aids the clinician in effectively maintaining lung protective strategies. Without this feedback device, it is difficult for clinicians to achieve and maintain accurate targeted inspiratory pressures. Numerous articles suggest that barotraumas begin at pressures greater than or equal to 35 centimeters of water. Use of an integrated pressure manometer allows a clinician to avoid dangerously high delivered pressures. Use of an integrated manometer can be an effective diagnostic tool. If pressure requirements change while ventilating a patient, it can be an indication of serious physiological changes such as pneumothorax, tension pneumothorax, or pulmonary edema. It can also indicate other issues such as an occluded endotracheal tube or tubal migration. Harmful hyperventilation occurs when too much volume is delivered in too short a time frame. Hyperventilation causes alkalosis, high intrathoracic pressures, a decrease in CO2, and many other complications. Maintaining lower inspiratory pressures with the use of a manometer naturally limits the number of delivered breaths per minute, resulting in increased inspiratory times and reduced chances of inadvertent hyperventilation. Working in concert with impedance threshold devices. Impedance threshold devices, or ITDs, are effective in creating and maintaining a negative pressure gradient to allow for maximum cardiac preload during CPR. It is important to understand the synergies between monitoring peak airway pressures during the ventilation phase of CPR with ITDs. Removal of the ITD during CPR to clear vomitus interrupts the negative pressure gradient that has been established. The quality of the CPR effort is compromised while the negative pressure gradient is re-established. Delivering lower inspiratory pressures during CPR with the use of an integrated pressure manometer helps to avoid increasing intrathoracic pressures, gastric insufflations, and subsequent vomiting and aspiration by the patient. Affordable integrated pressure manometers are available on all VentLab resuscitation products. For more information, go to www.ventlab.com or call us at 800-593-4654.